Ladies and gentlemen, my name is Samir Jaber. I work in Montpellier, France. The global burden of postoperative death is summarized on this slide. Today, around more than 3 million surgical procedures were performed worldwide each year, and the postoperative death is the first cause of the death among all the causes. This slide summarizes the main perioperative modification of respiratory function. As you know, you have first the residual effect of anesthesia, analgesia drugs, the decrease of the cough first, the upper airway narrowing, the pain, the surgical stress, and all of this induce a decrease of lung volumes, which is called the restrictive syndrome, which is associated to a diaphragm dysfunction and atelectasis. All of this modification induced, as you know, postoperative complication, mainly hypoxemia and respiratory failure and lung infection. So all of this could be worsened by the fluid overload. So in the operating room during surgery, we should try to optimize ventilatory setting and management to avoid this normal lung of the patient to become an ALS lung. This is a challenging of optimization. That's why we developed the POP ventilation concept with our team, which is the perioperative prophylactic positive pressure ventilation to optimize ventilatory management. This included the three parts of the perioperative surgery. First of all, during intraoperative period, we recommend to apply a low tidal volume between 6 to 8 milliliters per kilogram. That means is to avoid a high tidal volume, a PEEP around 7 centimeters water between 6 to 8, associated to recruitment maneuver. Associated to this procedure, we recommend to start earlier the pre-oxygenation with a positive pressure ventilation using CPAP or non-invasive pressure support ventilation, and after surgery, in some patients, use prophylactic non-invasive ventilation. So why start with a pre-oxygenation using positive ventilation is to try to avoid the occurrence of this atelectasis. As you see on this slide, after induction, you have immediately atelectasis, which is the main complication and make the bed of the post-operative infection. So using a positive pressure, for this example, is a CPAP of 6 centimeters of water, you could avoid the occurrence of atelectasis. The second part is the lung protective ventilation during surgery in the intraoperative period. We reported first 7 years ago that the lung protective ventilation associated a tidal volume of 7, a PEEPs of 7 centimeters water recruitment maneuver in comparison to the standard ventilation at this period of the study, which was around between 10 and 12. It's at 11 with no PEEP, with no recruitment maneuver. This standard group was the group that was the surrogate of the period of the study. Now, I hope that this is changed. The results of this improved study showed that using this lung protective ventilation, we could decrease from 28% of postoperative pulmonary and extrapulmonary complication to 11%. This is obtained by this lung protective ventilation in abdominal high-risk surgical patients. So, our concept is a bundle concept of protective ventilation. This bundle consists of avoid large tidal volume to avoid the ventilatory-induced lung injury, avoid high airway pressure to avoid all the injury due to high pressure, and we should always avoid the atelectotrauma, which to avoid the collapsus and atelectasis. To perform this, we should limit the tidal volume between 6 to 8 ml per kilogram, and we should try to use a significant PEEP, probably more than 5 centimeters, and probably more in some obese patients. So, where does the beneficial effect come from the protective ventilation bundle? Is the respective individual effect of a low tidal volume, or the PEEP alone, or recruitment maneuver alone? So, to try to answer this question, some others performed nice studies. First of one is the Provelo study, which compared low versus high PEEP alone using the same tidal volume at 8 ml per kilogram, as you know, and using a PEEP of 12 centimeter versus a PEEP of 2 centimeters of water in abdominal surgery high-risk patients. Unfortunately, no significance was observed between the two groups, that mean high and low PEEP. You see in this Kaplan-Meier curve that the complication was around 48% in both groups. This was not significant. More recently, in this nice paper, the same was done in the subgroup of obese patients. However, the other compared 12 centimeters of water, high PEEP, versus 4 centimeters of water at the same tidal volume. Again, no significant difference was reported in the pulmonary complication. As you see, here is around 21 to 24%. So, what about the tidal volume? More recently, in this early period of September 2020, a very nice study was published in the JAMA compared low at the 6 ml per kilogram versus conventional tidal volume at 10 ml per kilogram at a fixed PEEP of 5 centimeters of water. Again, unfortunately, no significant difference was observed between both groups, as you see the group of 6 milliliter and the group of 10 milliliter per kilogram. The complication was around 38 and 39%, what was the composite respiratory complication within the 7 day in postoperative surgery. Again, no significant difference. So, why postoperative complications were decreased only in the IMPROVE study and not in the other study? Probably my answer, this is my point of view, is that low tidal volume or PEEP alone are not sufficient. And where does the benefit come from? Is it lower tidal volume, PEEP, or recruitment maneuver? My answer is probably all together, not one. You cannot observe any effect if you just applied one component of this bundle. That's why the explanation could be done by the multifaceted approach of the bundle is probably the key in this, and probably we could discuss what should be today the standard group of comparison. So my main message regarding the more recent literature is that low tidal volume alone, probably less than 8 ml per kilogram, is not enough. PEEP alone, probably at 5 centimeters, is not enough also, and recruitment maneuver alone is not enough. So what should we recommend is to consider in surgical patient a protective ventilation bundle which associate low tidal volume around 7 ml per kilogram, optimal individualized PEEP, positive and expiratory pressure, around 7 centimeters of water, and recruitment maneuver should be performed at least each 30 minutes during surgery or each time when you have a de-recruitment, such an extubation or a suctioning at this period. Thank you very much for your attention.